I am here to present on a typical topic that is very, very critical in most individuals, because as we grow every day, we experience a lot of things. And one of those things is pain, because we are humans and we keep moving. So today, this webinar comprises knee pain and knee osteoarthritis as the main point of discussion. In knee osteoarthritis, we are going to be talking about the guidelines and the evidence-based practice in this, our modern day, all over the world, that is internationally accepted and is used to treat knee osteoarthritis. And as a physiotherapist by profession, it is important for me to advise everyone who may or may not have this kind of condition the importance of the treatment in osteoarthritis management. Physiotherapy is a conservative method of managing osteoarthritis, and it's important that everyone that has a case that is close to this should be attentive and listen, or you have somebody that also has a case like this, you should listen and know the preventive measures, how to curtail this, how to minimize the complications, so not to lead to severe case, which can also lead to surgery. So, knee osteoarthritis topic, guidelines, evidence-based physiotherapy management. Now, this presentation is being done under the umbrella of Amazing Physiotherapy Wellness Center, and our vision in Amazing Physiotherapy is to be the leader in healthcare services, both outpatient clinics and home services, providing pain and movement solutions with high standards, morals, good ethics, and professionalism, commitment, purpose driven by godly principles. And today, as part of our vision, we are handling pain and movement solutions for you. So our mission also at Amazing Physiotherapy is to help people get back to living the life that they deserve, which means a life free from painkillers, where you don't have to worry about bothering the medical doctors and can do and enjoy all things without fear of pain holding you back, which is also our mission today by conducting this webinar. I want to thank my highly esteemed Dr. Nnamdi for giving me this opportunity. I really appreciate it, sir. And the outline for this, my presentation today, includes introduction, epidemiology, relevant anatomy, pathophysiology, etiology, clinical presentation, risk factors, diagnosis, prognosis, and management before we get to conclusion. My name is Dr. Okeleke Chukuma. We begin. Knee pain. A lot of people have managed knee pain for several years. Some people wake up with it, and by the end of the day, it is gone. Some people, it is after the day's activity, the activities of the day, involving work and stress and all that. After doing the activities of the day, they start feeling pain at the knee. Some of them do a little massage by themselves, that's self-medication and treatment, and by the next day, it's gone. But there are some group of people that this knee pain can last for up to a week, for up to 2 weeks, and they keep trying their best to know if they can handle this. And at the end of the day, maybe after 7 days, they end up in the hospital where they see a doctor, and the doctor first prescribes a pain relief for them. But what you have to understand is that if the necessary investigations are done and it is found out that it is knee osteoarthritis, the first line of treatment for osteoarthritis in all stages is physiotherapy intervention. This is also approved by the International European Society for Osteoporosis and Osteoarthritis. Then, let us explain what is knee osteoarthritis. Knee osteoarthritis is also known as degenerative joint disease is caused as a result of wear and tear and progressive loss of articular cartilage. OA as a degenerative joint disease is typically as a result of wear and tear, overuse, over time. That is why it is mostly in the aged. But because of some certain activities which the younger ones may have engaged in, which can lead to injury at the knee and other activities that can cause injuries to the knee, they can also develop osteoarthritis at a young age. So, epidemiology. Now, we are trying to give a detailed estimate on how osteoarthritis affects people in the world. OA affects nearly 6% of all adults in the world. Roughly 13% of women and 10% of men 60 years and older have knee osteoarthritis. Symptomatic, that means they present with the symptoms of knee osteoarthritis. Among those elderly, more than 70 years of age, the prevalence rises to 40%. So as the person that has osteoarthritis at the age of 60, as you are getting to 70, and continue to increase, because this is a damage to the articular cartilage. And while movement is continuous and there is stiffness and all the symptoms of osteoarthritis coming up, it gets worse for the patient if not properly managed. So prevalence also increases in patients that are overweight and older patients, that patient with life expectancy, maybe patients that can get up to 90, 100, and so on. Patients that are overweight, obesity is also a factor here. Now, Amazing Physiotherapy Wellness Center has seen and discharged over 80 clients with osteoarthritis successfully since inception. And this is a wonderful feat because patients with osteoarthritis should be glad that there is a solution here in Amazing Physiotherapy. Now let's get to relevant anatomy. The human knee comprises of 3 bones. Majorly of 3 bones. We have the femur superiorly, we have the patella, which is anterior to the femur, we have the tibia inferiorly. And now, these joints are connected by ligaments. And these ligaments are, we have the anterior cruciate ligament, we have the posterior cruciate ligament, we have the lateral and medial collateral ligament. And also we have some structures that cushion the knee joint within, which is the meniscus. We have the meniscus, both medial and lateral, sitting on the tibia. We also have the capsules, which also help to cushion and protect the knee. We also have different bursae in different locations, superiorly and inferiorly and superiorly. We have that there are muscles around the knee joint that support movement. We have the muscles that controls flexion. We have the muscles that controls extension in the knee joint. The quadricep muscle controls extension in the knee joint, that is keeping your leg straight, your knee straight. Then the hamstrings controls the flexion of the knee joint. That is a situation where you have to bend your knee. It's controlled mainly by the hamstrings. Then we have 3 muscles that make up the hamstrings. We have 3 groups that make up the hamstring. We have semimembranosus, we have semitendinosus, and we have the rectus femoris muscle. The quadricep too, as the name implies, quad. There are 4 muscles that comprise of the quadricep. We have the intermedius, we have the lateral part of the quadriceps, we have the medial, and we have the intermedius with the all right, thank you. So let's go ahead. Tendons of the knee. There are tendons that you feel when you touch your patella superiorly and inferiorly. Now, the tendon that you feel superiorly is the quadricep tendon. Is the quadricep tendon, exactly. And now, the structure that you feel inferiorly is the patellar ligament. Now the patellar ligament connects the patella to the tibia, and now the quadricep tendon connects the quadricep muscles in bulk to the patella from up. Now, most of these muscles and structures that I'm mentioning now are the ones that are typically affected in osteoarthritis. When you talk of the late second stage and third stage and the first stage. As we continue, you will get to know more about it. Now, when we talk about the types of the OA and the causes, we have that the types, the causes could be of primary source and it could be secondary. The primary source is not really known, but it is more in the elderly because of wear and tear and overuse over years. And it is generally caused by the wear and tear in the joint, because the knee is also a weight-bearing joint of the body. So when you are standing, when you are walking, when you are running, you are using your knee joint. All these motions have an effect on the knee joint. The secondary cause is mainly due to an external factor, maybe due to a fracture of the tibia within the joint, maybe a tear or rupture of the meniscus or any other ligament that could be affected, thereby causing instability within the joint, and the bone surfaces, which are coated by the articular cartilage, tend to come in contact with each other. And also other factors that can also cause osteoarthritis, which are the secondary factors, obesity, instability, just like I mentioned just now, malpositioning of the joint, people that have deformities like genu valgus and genu varus, previous injury to the joint, which could have led to hematoma, increased swelling or bleeding within the joint, then loss of synovial fluid and other congenital defects can also is also like a secondary cause of knee osteoarthritis, where we have children that are born with deformative epiphyseal plates. Maybe the tibia or the femur is not well structured from birth. Immobilization and loss of mobility, people that are bedridden, in coma, for a long time, people that are not, people that are living a sedentary lifestyle, they don't move around a lot. Family history, it could also be genetic source, metabolic causes, like people that have rickets, due to deficiency of certain vitamins and nutrients. Okay, now moving over to pathophysiology. Now we want to discuss what is the leading factor that leads to osteoarthritis. How do I know that in future I will not have osteoarthritis? What are the stages that osteoarthritis goes through to get to that point where I start feeling pain and all that? Now, this articular cartilage that coats the bone within the joint is normally maintained by some chemicals, which is proper functioning and structure of the matrix. Now, if these chemical components are being disrupted to carry out the function they are supposed to carry out, they would not do the work that they are supposed to do, making the cartilage to lose its integrity, and the matrix will also lose the proper structure that it's supposed to have, and it starts to break down. It's a series of chemical reactions that go on within the joint, and it is caused by this wear and tear that we have been talking about. And this wear and tear, the effect is felt more while you are getting older, in the elderly. So it is necessary for us to always look out for our joints. You don't just start having some kind of feeling and you feel like it is what the paracetamol can handle and you can rest. You have to be careful how you handle yourself also. You can't squat for like 2 hours doing something and your knee is paining you and you don't feel like standing up. Most of these scenarios lead to OA later in life. I'm not trying to scare anyone, so let's just continue. So as the presentation goes on, we'll still understand better. Then when these reactions are disrupted, there is changes in the matrix of the cartilage. The matrix is formed by the collagen fibers, and when this matrix is being disrupted, the cartilage begins to crack, and it starts to peel off, to chip off little by little from the surface of the bone. And when it starts chipping off, so with time and with the wear and tear too, the person tends to be walking, moving around, feeling like, okay, this is a slight pain, and you continue. This increases the chipping of the cartilage, thereby causing more damage. The cartilage starts eroding, and then since the cartilage has been damaged and there's little or nothing that can be done to recover the cartilage, the surrounding structures are also affected. And when this cartilage has been exposed to so much damage and it doesn't coat the surface of the bone that much, the bones within the joint tend to move closer to each other, leading to narrowing of that joint. And when there is narrowing of the joint, because there is no cartilage to make the surface smooth without friction, the surface of the bone looks corroded. And when they come in contact with another bone with same features, it causes a major pain, stiffness. The joints become stiff, and movement is difficult at this point. The cartilage will continue to wear away, and the bone will also expand. That is, there will be some bone growth, mostly at the sides of the bone itself. That is within the joint, having contact with other bones. And then there is also laxity of the ligaments. That is, the ligaments are also weaker. They are not firm again. There is no integrity. And then these ligaments are the ones holding the bones together. And since they are weaker and they are not strong enough, the bones continue to touch each other. And you know, within a joint, bones are not supposed to touch each other, so that movement will be smooth and without pain or stiffness. So most of these things happen within the joint, and it happens without the patient really knowing what is going on. So the patient may even expose him or herself to certain activities that will even increase this process, the rate of this process. Now, clinical presentation. What are you going to notice? You are going to notice pain in lying down or sitting. You are going to notice pain. And then there will be stiffness. There will be loss of range of motion. That means movement in the joint will be reduced. You may not be able to stretch your leg the way you want. You may not be able to bend the way you want because of stiffness and pain. Crepitus, there is also a sound that you hear. That is the sound of bone surfaces touching, like a cracking sound that you hear within the joint. Inflammation also, because there is damage in the joint already. The first response of the body to injury is inflammation. So inflammation starts the process of healing. Joint enlargement, which can also be seen as swelling of the knee joint. Then, as an individual, when you start experiencing things like this, you know that there is a need for you to meet a physiotherapist. Number one, early morning stiffness in the joint. Dull, achy pain within the joint. Pain after sitting and you want to stand up, you start feeling pains. Pain after increased activity. Maybe after a sporting activity, you start having pain in your knee. Maybe after walking for long distance or standing for long, you start feeling pain in your knee. Reduced mobility. You find out that your knee is not limiting you from doing certain activities. You cannot stand up when you want to. You cannot move around when you want to, because there is pain in your knee. Difficulty in weight bearing because of the affected knee. When you are standing, is weight bearing. So in standing, you start feeling pain in the knee more, making you not to stand for long periods. So decreased ability in daily functioning. Like I said before, it will start affecting your activities of daily living. You cannot be able to stand up when you want to. You can't walk to the distance you want to. You can't run when you want to. And all that. It is important that you take note of all this and try to visit an expert to look into it and find out the best way to handle the case. Now, there are different grades of osteoarthritis. We have the 0 level, which is the normal knee, before we start with grade 1. Now, grade 1 presents with no obvious significant bone growth within the bone, just minor spore growth. And most of these features are seen in an X-ray. So as a physiotherapist, when the patient presents with an X-ray, or when a patient comes and you are suspecting knee OA and the patient goes for knee X-ray and brings the X-ray forward, these are the things that you'll be looking out for in grade 1, grade 2, and grade 3. In grade 1, there's no pain for the patient, there's no much discomfort, just occasional pain. And then there's minor bone growth and degeneration on the bone surface. You will see the features of degeneration on the bone surface. It's like the bone is degrading at the epiphyseal plate region. And then the grade 2 is moderate. This is the first time the patient starts feeling some kind of discomfort or pain that is worrying. And then stiffness for longer time. The patient now observe that the person now observe that maybe when I sit for long and I try to stand up, I hear a sound, and then it's like my joint is stiff. But when I move around a little, I feel better. That's grade 2, and it's the moderate level. So at that point, you should know that if a physiotherapist starts handling you, there will be no need to do surgery in the long run. Grade 3 is the moderate OA. Now the patient start having frequent pain. Now when the patient move around for a while, the pain does not reduce like before. And now early in the morning, the joint is now more stiff than before. The patient will start noticing having major occasions of stiffness in the joint. And now in grade 4, we have the severe one. Now, in this grade, the joint is now narrow. The two bones, the femur, that's the bone at the top, which is found superiorly, and the one that is inferior, they are now very close to each other. So there is limited movement in that joint, and the bones are coming in contact with each other occasionally, leading to more pain, stiffness, and now what will happen to the surrounding structures, like your ACLs and your ACL and your PCL? What will happen to them? Because these are the structures that are holding the bone in place. Most of them become lax and they collapse, causing more pain within the joint. That is why most patients complain of pain within the joint. So now for grade 4, it is very severe. And most patients, when they come in contact with orthopedic surgeons, they are told to go straight for knee replacement surgery, which we'll discuss later. So now, what are the risk factors? What can make you prone to knee osteoarthritis? Now we'll have joint injury or overuse. Joint injuries like sports injuries, people that have ROTA fractures within the knee joint, like I mentioned before, can lead to a progressive or a knee osteoarthritis. People that are greater than 50 due to aging. You know, aging is also a process that is inevitable as long as you are alive. So as you age, your cells age with you. It's not like your cells become younger, you know. And as your cells age, there are some certain things that you cannot, that they cannot perform again. They get older, and some of these functions, like the chemical balance I said within the joint, will tend to be altered also. And also at that stage of aging, this wear and tear, the effect of wear and tear over time, right from when you are young, stressing your knee the way you like, you are squatting even when it's not necessary, you are jumping and moving in aggressive manner that can cause damage to your knee. Most of these things tend to cause problems for people later in life. Now, gender. It is more in females than in males. Now, since gender is an issue, the females should also be looking out for this, especially in their menopause, because during menopause there are hormone level drop. So because of the hormone level drop, most of these hormones alter the integrity of the ligaments, and when these ligaments are not firm enough to hold the bones, the joint tends to narrow, and thereby making the person susceptible to osteoarthritis. There's also obesity, overweight. You know, the knee joint is a weight-bearing joint. So if you're overweight, most of the impact will be in the knee. It will be in the lower leg, but most of the impact will be in your knee and your ankle. So now for diagnosis, like I said, X-ray can be done, arthrocentesis, where the synovial fluid, a fluid is taken from the joint to test and know the nature of what is going on there in the fluid, and if there is a risk of infection within the joint and all that. Arthroscopy is a feature which involves using of a small camera to view what is happening within the joint. Then we have MRI. MRI is more advanced than X-ray. This is for people that don't really understand. MRI shows soft tissues and if there is any damage to them. But the X-ray is focused on bones, the hard tissues. So that is the major difference between MRI and X-ray. So we also have the differential diagnosis. We have meniscal pathology. There are some tests that I will conduct to differentiate some of these differential diagnoses. We have gout, we have septic arthritis, infection within the joint, we have hip osteoarthritis. But what we are focusing on today is knee osteoarthritis on the knee joint. Referred back pain. Sometimes your back pain can radiate to your hip and also radiate to your knee, thereby making the person to feel like, oh, I have a problem in my knee. And some people may now conclude that it is knee osteoarthritis. So there are some tests that we use to rule that out. We have ligamentous injuries. We have injuries to the different ligaments that are holding the bones together within the joint. And when there is injury to some of these ligaments, the instability of the joint is altered, which can lead to osteoarthritis. And then the prognosis. It depends on the age of the individual. So if you are elderly, you are prone to have osteoarthritis. And if you detect it on time and treatment is being carried out, then you will have longer expectancy. But if you delay and it gets to the severe stage, physiotherapy intervention is still the first line of treatment before you start talking of surgery and all other forms of treatment. It is widely accepted, and that is what we are advising people to take on today. Then the number of risk factors also. So if you have up to 3 of the risk factors I've mentioned, you're obese, you're a female in your menopause, and then you are above 60, you are above 50. That means you should look out on how to prevent cases like this. And severity of abnormalities. Maybe if the patient also have other complications like diabetes, maybe fracture to the tibia, immobilization at a younger age. I have seen elderlies that were involved in a ROTA, that's a road traffic accident. I've seen elderlies that have been that have dementia and they don't really know or how to describe what is really happening there in the knee. And I've seen patients with stroke that also have knee osteoarthritis. So most of these factors give poor prognosis. But how we should get a good prognosis in osteoarthritis is to detect early. And it is part of the reason why we are giving this presentation today. When you detect early, you will be safer in your journey of life. So in management, there are 3 methods of management. We have the pharmacological part, we have the surgical part, and we have the physiotherapy intervention. The pharmacological part involves the use of drugs, mainly pain relief. We have the surgical part, which involves total knee replacement. We have the physiotherapy intervention, which is what we are focusing on today, that also involves surgery or pain relief or drugs. Now we move on. Now, physiotherapy is a conservative method, and it is using physical means to achieve a particular goal in a treatment of a condition. We diagnose, we assess a patient based on the presented parameters. And we narrow it down to a particular cause and find out the major reason why the patient is having this issue. Just only find out the risk. We also look out for preventive measures for the patient to avoid future complications, to avoid a reoccurrence and all that, thereby giving the patient the life he or she deserves. Now, for our objective assessment, we start with observation. Okay, right about now, I'll be doing some demonstrations to further explain what we are discussing today. And at some point, I am going to demonstrate some exercises which some of our listeners out there can engage in at home and help relieve some of their knee pain and prevent osteoarthritis. Also, if you are in the mild phase of osteoarthritis, most of these exercises will help you to prevent further damage or complications. And most of this treatment of physiotherapy is focused on relieving pain and improving the general function of the patient. Now, I am going to start my demonstration now. Okay. You're welcome. You can sit down. This is my model, Mrs. Ezioma Phillips, a wonderful personality. So I am going to demonstrate some of the tests that we do for knee osteoarthritis as physiotherapists for us to see. Okay, you can lie down with your head inside. Okay. So now, observation is very important. It is important to note and observe. As a physiotherapist, it is part of the skill that we have as physiotherapists. When we see a patient walking or we see a patient coming into your treatment room, you observe. You check how the patient walks, if the patient is walking with pain, if the patient is in distress, or if the particular point where the patient is complaining of is swollen or is lean, that is in the aspect of atrophy. Now, when you observe, most times in severe knee osteoarthritis, the knee is swollen. So, but there are other cases that can lead to the swelling of the knee. There are other cases that can cause the knee to swell. And most of these cases can also make the expert to just believe that it is knee OA. Meanwhile, it is not. And you know that as a physiotherapist, if you are not looking out for the test that will rule out certain conditions and you start treating the wrong condition, you won't achieve a good result. So that is why the assessment is very, very important. So first of all, we observe and then we palpate. We palpate the surrounding tissues of the joint. Most times these patients, they feel pain in the muscle insertions, where the muscles insert across or over the joint. Now, we have the quadriceps on the patella, the quadriceps tendon attaching to the patella. You palpate the superior part of the patella for pain. Most of them feel pain more inferiorly, that is within the patellar ligament. So when you palpate and the patient feels pain, then you note it. Now, the next thing is to do patellar mobilization. Patellar mobilization is a test that is done to know if the patella is mobile. Now, when you want to mobilize the patella, you have to lock with your palm on each side and make sure that, because there are some patients that have hypomobile joints, and in hypomobile joints, the joint is unstable and the patella can easily displace, especially in the knee joint. So you have to be careful by supporting the patella superiorly and inferiorly, like this. You support and then you assess with your thumb at the medial part and your index fingers at the lateral part. Then use your thumb to push sideways and use your index finger to push medially, and then use your thumb to push laterally. And then you can use your index finger and your thumb of the upper hand to push down the patella towards the lower hand that you have placed to stabilize. And then you check for crepitus and pain within the joint. Now, the next thing to check is range of motion. Range of motion is the movement within the joint. First of all, you will tell the patient to flex his or her knee. Okay, bend your knee. Good. When the patient bends knee, you observe the countenance of the patient. You observe if the patient feels pain, and then you also ask the patient, do you feel pain? At what point do you feel pain? Now, most patients feel pain at certain range while flexing, while most patients can't even flex at all because of the severity of the knee osteoarthritis. And now, when the patient flex, in some patients, you hear some sound. That is the crepitus. And when you feel, as a physiotherapist, and you tell the patient, okay, bring down your leg now, with your palm on the patella, you don't compress the knee joint, but you just hold on to the patella to have a feel of what's going on in the joint, and then you tell the patient to flex again. This gives you an idea of what is happening in the joint. As a physiotherapist, you feel the crepitus. It is one of our skills. When you have gotten to the level where you can understand certain movements in the joint, you will know when there is crepitus in the joint, and then you will feel it, the vibration of the crepitus going through your palm while the patient is doing the movement. And now, next in line is to do what we call passive range of motion. Now, the patient will not make any movement. What the patient did initially is the active range of motion. Now, for the passive, the patient will not make any movement. I will be the one making the movement for the patient. So I'll tell the patient to relax, then I flex the knee. Once I flex the knee, I ask the patient, at what point do you feel pain? If the patient feels pain on flexion towards end range, then I stop there and try to glide to know if the patient also feels pain. The essence of this gliding is to stretch the side structures of this joint, to rule it out to some extent. Because now in flexion, I am stretching mainly the anterior structures. So I glide the side structures to make sure that I'm ruling some certain factors out. Now I also extend, and the patient may tend to say, okay, I am feeling much better in extension. Now I will also check the strength of the muscles of this patient. Now, grading is very important. Muscle grading, where you have to check the strength of the patient using Oxford grading. Now, I'll tell the patient to extend while I hold the base of the heel, to flex while I hold the base of the knee, flex your knee. Then I try to resist to find out if the patient is the strength duration and the level or grade of the strength of the muscles of the knee joint. And now we also ask questions of normal functional activity. How long do you stand? Do you stand for long? Do you have problems standing up? Do you have problems running? Do you have problems carrying out certain activities of daily living? And the patient may complain that he has problems standing and all that. Now, this objective assessment also involves some special tests that are carried out. We have tests that will rule out the ligaments that are implicated, if the ligaments are implicated within the joint, to rule out those factors and make sure that what we are handling in this joint is knee osteoarthritis. Now, like I said before, we have the anterior cruciate ligament and we have the posterior cruciate ligament. These are ligaments within the joint holding the tibia and the femur within the joint. They are close to being injured also within the knee joint. So from now, I'll do the anterior drawer test to check the anterior cruciate ligament. This test tends to stretch the ligament and find out if there is injury. Then I'll pull. So the therapist sits with the knee of the patient flexed, and the therapist sits on the toes with firm support under the knee joint, and then you pull the tibia, that is this bone that is below, towards yourself as a physiotherapist. Then you find out if the patient feels pain. Then for checking the posterior cruciate ligament, we push towards the patient to check if the patient feels pain. Now, to check for the medial collateral ligament, you can flex or extend the knee joint to some extent, and then you apply pressure at just 4 inches above the knee joint. You apply pressure, holding the ankle at the base here, holding the ankle. Then you push with your left hand on the opposite side, moving your ankle on the other side, and then you stretch the side of the knee to find out if the patient feels pain on the medial collateral ligament. And then to check for the lateral collateral ligament on this side, we have the medial collateral ligament on the other side, on the inner part of the thigh. Then we have the lateral on the outer part of the thigh by the side there. Then you also push. For some therapists, they tend to move to the opposite side and then push backwards like this to test. Now, most of these tests rule out the ligament that are implicated. We also have McMurray's test, which involves flexion and rotation or gliding of the knee joint at that end range of flexion to test if the meniscus cushioning the joint within is also damaged. We also have tests that also check if the quadricep muscles in front of the thigh is tight, and to check if the hamstrings at the back is tight too. Also to check if the patient also feels pain at the calf muscles, which is just below, at the back of the leg, just below the knee joint, because most patients also feel pain there. And then we also carry out some McMurray tests with the patient lying down. Can you come face down? Okay. With the patient lying face down, good. We flex the knee, and then for us to check the lateral part of the meniscus, we move the knee joint towards ourselves like this, and then we tend to glide and rotate. You glide and rotate to check if there is an injury, and when you want to check the medial part, you move away from yourself and glide and rotate. Glide and rotate. This is to check the meniscus within the joint, because most times patients come up with severe pain within the joint and they feel like maybe this is arthritis. So most of these things should be ruled out to prevent further complications within the joint. Okay, you can turn and face up now. Good. So now, further investigation is also carried out with X-ray, where the therapist is not sure of what is really going on in the joint. The therapist requests for X-ray or MRI to further diagnose and find out what's going on in the joint. And when this MRI is brought, or when the X-ray is brought, the therapist has to look out for the different grades to know the particular grade where this patient is at, and then totally rule out every other condition. So now we are going to look into the plans why physiotherapy is important for this osteoarthritis, which causes knee pain. Now the plans. One of the plans is to reduce knee pain. Another one is to increase range of motion within the joint, strengthen lower kinetic chain, improving all-round functional physical function of the patient, and also the type or the way the patient walks, to improve on it. We also improve on balance and agility of the patient. We also advise and educate the patient on the need for prevention and the need for care to prevent complications. You understand? So most of these patients don't really know what to avoid. So we are the ones that advise them on what to do and how to do them. Now, the physiotherapy intervention involves manual therapy and exercise therapy, which is the major form of treatment for knee osteoarthritis by a physiotherapist, as proposed in 2019 by the European Society for Clinical and Economic Aspects of Osteoporosis and Osteoarthritis. In this their research, they came up with 3 ways majorly that every stage of osteoarthritis should be managed. Number 1 is education of the patient. So the patient should be advised on positioning, movement, and all that, what to avoid and what not to. The patient should also be advised, if the patient is overweight, on weight loss before we now start doing the exercise program. These are the 3 major factors that they highlighted that every patient with osteoarthritis should work on. And now, going further to whether the patient has pain in the acute phase of osteoarthritis, with patients that come up with the different symptoms, there are some thermal agents that can be used, heating modalities, and then manual therapy with exercise is the most important, which they highlighted. Other means which can be used is also acupuncture, patella tapping, and balneotherapy, which is like your spa treatment. Before you now start talking of pharmacological treatment, that is, if you are incorporating all these steps that they have mentioned and you are still having severe pain, then you will consider the pharmacological relief part. So now we are going to discuss about and demonstrate about some certain exercises that you can incorporate and take up as an exercise program for your knee osteoarthritis. Now, we have the quadriceps, we have the hamstrings, and we have the other muscles, the pes and serratus inserting here. There are other muscles that are also attached as part of this knee joint. Good. Now, we are going to incorporate strengthening programs for her now. And we're going to teach you how to strengthen some of these muscles and get your knee working better. But before then, I want to do some gliding, because as part of knee osteoarthritis treatment as a physiotherapist, manual therapy, which has been indicated already by the Society of Economic Aspects of Osteoporosis and Osteoarthritis, manual therapy involves manipulation, gliding of the joint structures to stretch some of the structures and relieve pain and try to improve the integrity of these structures. You try to introduce a mechanism that will make some reactions to start to improve the joint. Now, one of these manipulative methods is your gliding, which I did for a test. This anterior glide helps to relax the anterolateral backbone of the knee and also stretch the structures like your ACL2. Some of the ligaments inside are being stretched, thereby helping the patient to relieve pain. Then we have another form of gliding that we call the tibiofibular gliding. This tibiofibular gliding is done like you want to do your MCL and PCL test, holding the ankle at the base there with your hand on the knee joint, and then you rotate the ankle from medial to lateral, or lateral to medial, either way. Good. Now, we also have some kind of gliding that is done in knee flexion to also get to the side structures of the knee, which involves side-to-side gliding of the joint there, that is femur on tibia, the bone above on the bone that is lower, superior and inferior. Now we have this movement holding the medial part of the leg below and the lateral part of the thigh. And then I push with little force to the opposite side to glide the joint. I will also change my hands on the same positions and glide again. Good. Now, another form of gliding, which is very important, is the prone lying. In prone lying, then you get a towel or a piece of cloth to support the knee joint and the back, placing the towel on the thigh posteriorly to support the knee joint and the back. This also helps, and then the therapist flex the knee, trying to get the heel to the buttocks, and then this also helps to give us our anterior glide with your towel or a piece of cloth at the knee joint. Then you press forward, and then you get the glide that is required at that knee joint. A lot of patients tend to feel pain, so you try to minimize the way you flex the knee, because if you expose the patient to excruciating pain, it might be discomforting for the patient. So the patient has to feel mild to moderate pain, and with continuous repetitions of the stretch and gliding, the pain will be relieved to some point. And then with manual therapy and exercise, it has proven that intervention of physiotherapy is paramount in the treatment of osteoarthritis. Now, there are other exercises which can be done personally at home. Some of these exercises involve the stretching of the muscles, like I was saying before, the quadricep, the hamstring, and the calf. Some of these exercises are done with TheraBands, while some are done with weight, sandbag. Okay? Now, we want to do the hamstring stretch, and the patient is told, this is for some people that would like to be doing their home exercises. Now, you would just align the TheraBand, linear TheraBand, at the base of your foot, at the plantar part. Then you hold with your two hands. Good. Now, you try to raise your leg up straight like this. Good. Now, while doing this exercise, you are stretching with this, trying to resist at your ankle, and then keeping the knee in extension and stretching eccentric contractions for the hamstring. Very good. Now, bring it down. Then we have other exercises. Modified SLR, flex this knee. Good. Now, raise this leg straight to the level of this knee, of your leg. Good. We have other strengthening exercises like SLR, which also help the patient to strengthen the thigh muscles and get them stronger and functioning well. Good. Bring your leg down. Good. We also have split squatting. Good. I want you to stand up. We also have split squatting, where the patient is told to hold the bed and then stand on one knee, stand on one leg, and kneel on the other one, while the other one bends too. Good. Let's go. So, yes. Good. This is what we call split squatting. Good. This exercise helps to improve the range of motion within the joint, because the joint has to be in steady movement daily. At least there should be 10 to 12 hours of movement within the joint. Not a month that you must be carrying out any activity, but while you are lying down or you are sitting down, you can do some exercises. Now I want you to sit. Good. Keep your legs straight. Good. Now in sitting, this can be done too, to strengthen the muscles that are connected to the knee joint. Because in strengthening these muscles, the idea is to make sure that these muscles help to cushion this joint. Because if the muscles are holding the bones together firmly, there will be no need to be scared of the bones touching each other within the joint. Because the bones are not supposed to touch each other within the joint. And if the muscles are strong enough to hold the bones and they are not touching each other, it will better give the cartilage a better environment not to damage further and corrode, thereby giving it a possible environment for it to stabilize and start getting back to the normal chemical equilibrium that will aid its integrity. Thank you very much. Then we have other activities where you can tie a TheraBand to the bed and then ask the patient to move to extend the leg. Take it up. Good. We have other exercises that you can do using your TheraBand to help extend the leg. And now we have what we call the leg press. Good. Now lie down. We have what we call the leg press. We have different modalities that you can use for leg press. Now hold your two hands. Good. Sorry. Hold your two hands. Good. Now bend your two knees. Good. Now press forward. Extend. No. Stretch. Good. Good. Press forward. Good. So the patient can use a TheraBand to do leg press where the patient has to flex the knee and extend, thereby also stretching. And then with this exercise, the knee joint range of motion is increased and the muscles are also strengthened. And then there are other basic exercises that can be done, like sit-ups. You can sit down now. There are other exercises that can be done, like sit-ups. And then, okay, good. We have side SLR. In lying down, we have that the patient will be abducting the hip joint like this, repetitively. And then we have the rotatory or circular movement that can also help the patient to strengthen the hip muscles, thereby extending the overflow to the knee muscles. Like this, rotation. You either do from anterior to posterior or posterior to anterior rotation. And then we also have bridging in side lying, where the patient can bridge in side lying, raise the pelvis upwards in side lying, and also we have bridging the pelvic push-up in side lying that can also involve abduction of the hip in young patients with osteoarthritis. This exercise can be done personally and at home. Then your normal bridging involves taking your pelvis upwards while lying supine, face up, and your knee flexed. And this also helps. Also in modified SLR, where your leg is stretched forward in SLR, and you can also bridge, thereby strengthening the affected limb, which is flexed, and also strengthening the other limb, which is on SLR. So you can alternate for both limbs and get better results and strengthening. Other exercises that can be done also involve cycling, calf stretch, cycling, walking. A patient that has osteoarthritis who can stand and walk without severe pain is advised to take a walk every evening, if possible, every morning. And in a day, you can take 30 minutes walk. Improve the mobility within your knee and get those stiffness out. And most of this stiffness gets worse with reduced activity within the knee joint. So now we are not advising you that you should do high impact activities. There are some activities that you can do at home on your own, and some of them, in case for a person that doesn't have a cycling machine, you can do what we call the air cycling, where you lie face up and then move your legs like you're riding a cycle upwards. Good. So most of these exercises are very important to strengthen this muscle. And if a patient that is fully incorporated in doing this tends to go ahead and is committed in doing most of these exercises, you will come out with good and better results. So I would say that there is also a muscle at the posterior part of the leg, which is called the calf muscle. This calf muscle can also be painful in patients with osteoarthritis, and it is important to know that you can also do some of these exercises to strengthen them, like standing on your toes, sustained, and you count, or you do repetition of standing on your toes, and then you can do one leg stance of standing on your toes, and then you can also incorporate step ups. Step ups involve using a stepper to do this exercise. Now you get onto a stepper and then you stand on the stepper and then you come down again. It's not what you do rapidly. 1, 2, 3, 4. No, it's not what you do rapidly, but you do it slowly so that the target muscles will get the flow that is required. And then, in conclusion, I will say that knee osteoarthritis has a lot of complications if not well managed. But it is important to know that if the patient is quick enough to notice some of these difficulties early enough, there will be a great chance of avoiding a lot of complications in knee osteoarthritis, and life expectancy and prognosis will be good and better for the patient. Now, in conclusion, I will say that movement or physical activity is the best medicine for people suffering from knee osteoarthritis. Performing physical activity may not only improve your joint mobility, it can also improve your overall quality of health and can help reduce depression. It is very important. Exercises have to take place under the supervision of a physiotherapist first. And when properly instructed, these exercises can be performed at home so that it will not be done wrongly and achieve the wrong results. Though research has shown that group exercise combined with home exercise is more effective. That's why it is good to form groups, go out there and be active. Thank you very much. My name is Dr. Okeleke Chukuma, and I've come to the end of my presentation. God bless.